Hi, so this is my presentation, Born with a Heart Condition and Embodied Understanding. I'm sorry that I am unable to attend in person. I'll explain a little bit more about that later. I'm Dr. Liza Morton and I'm a counselling psychologist. I work in independent practice in Stirling, and I also lead the professional practice module on Strathclyde University's Clinical Health Psychology Masters. So, first of all, I'm going to talk about the psychosocial vulnerabilities of living with a heart condition from birth, and then I'm going to reconsider them through a polyvagal lens. So talk a little bit about polyvagal theory, and then in particular I'm going to talk about the implications of that for attachment, better humanising medical care, and informing therapeutic interventions. And then finally I just want to touch on challenging wider perceptions using psychologically informed advocacy. So just a little bit more about my background. So I was born with a complete heart block, and at 11 days old I was fitted with a pacemaker by pioneers at York Hill Hospital in Glasgow, and that was a world first at the time in 1978. So that was pioneering treatment, and it's involved numerous and countless interventions and hospital stays. Back then, the early pacemakers were set rate, so they were physically limiting. So there was no dancing or sports day or gym back then. And by the age of 7, I had been fitted with 5 different pacemakers by thoracotomy, so that's kind of through the ribs straight on the heart. When I was 12 years old, I needed a open heart surgery to fix a hole in my heart. And just to prove the point to you all, at the moment I can't come to the conference because my pacemaker lead has broken, and I'm currently awaiting surgery for my 11th pacing system to all be replaced. And again, that brings a lot of uncertainty. So making sense of my embodied experience has been a lifelong challenge. I've always had additional unexplained medical symptoms such as chronic fatigue, and that's kind of partly explained by what I'm going to talk about today. So just in general, a bit more about congenital heart disease. This is the most common birth defect. It affects 1 in 125 live births, and it's very much a success story of modern medicine. So nowadays, 90% of babies born with this condition will survive into adulthood, and that's compared with just 20% back in the 1940s. So we have this growing population of adults, and it's a very heterogeneous group. So you have people who have a simple hole in the heart, up to people with hypoplastic left heart syndrome, so they effectively have half a heart. We have people with transposition of great arteries, the whole kind of structure of their heart is different. And obviously people have had different interventions at different times. There's no cure for complex congenital heart disease, and lifelong monitoring is now indicated with increased mortality and morbidity burden. But just as a caveat to that, back in the early days of pioneering surgery, often surgery was considered curative, and a lot of infants were discharged and are now lost to care. So these are some of the interventions that are required for living with a congenital heart condition, and from infancy. And I just want you to take a little look at the slides and have a think about how you would feel having to face these interventions. Maybe as a baby, as an infant, a toddler, as a young child, and as an adult. And bearing in mind that the knowledge might be that you've experienced them before and will need to do so again in the future. So some of the things that you might feel are feeling lonely. There might be pain, terror, anxiety. There might be some guilt about the impact on your family, some shame. There might be some cognitions like, what if I die? I can't trust people. Do I somehow deserve this? It's my body. There may be some body memories from previous interventions. And we do know from the literature that it's now well established that people who are born with a heart condition are at an increased risk of a number of psychological difficulties. These are some of the psychosocial stressors that we may encounter. So there may be missed schooling. As I described, I wasn't allowed to take part in gym when I was younger. So physical limitations, living with an implantable device, facing transplant. There may be concerns around having and raising a family. Feeling different is quite a big issue that comes up time and time again in the studies. There may be bullying and discrimination. This is an unseen disability, if you want to call it that, which can have advantages but can also have make things a bit more difficult in terms of gaining employment and having your needs considered. So these are just some of the psychological problems that are known. So there's an increased risk of anxiety, depression, social withdrawal, post-traumatic stress disorder and reduced quality of life. We also know there are some developmental difficulties associated with congenital heart disease, and so they're listed here. So things like poorly developed motor skills, uncoordinated swallowing, reflux, high respiratory rate, fatigue, and problems with motor and language skills for infants. And finally, congenital heart disease is associated with a sort of low-level developmental delay. So cognitive difficulties, attentive problems and executive functioning problems, some impulsive behaviours and communication difficulties. And generally speaking, this population has a lower educational and employment attainment rate. Okay. And just to illustrate this point, this was a survey that was done quite recently at the Golden Jubilee National Hospital, where the Scottish Adult Congenital Cardiac Service sits. And they looked at distress levels among the population. So these were just people who were attending their annual checks. So they weren't there for any psychological intervention, they were there to have their heart checked. And just in kind of routine screening, it was found that 30% of those individuals were experiencing clinical levels of psychological distress, a quarter depression and a fifth of them anxiety. And of them, 64% were not receiving adequate psychological support. And unfortunately, at the moment, there is no dedicated psychologist attached to the adult service. We do now have a specialist psychologist attached to the paediatric service, but unfortunately not the adult service. So today, all of these psychological vulnerabilities have been accounted for by secondary factors. So, for example, feeling different, parental overprotection, missed schooling, repeated surgeries and hospital interventions. And of course, these may all be contributing factors. And it's difficult to disentangle the often complex underlying determinants. But what I want to talk today about is re-examining these findings through a polyvagal lens. And this is based on a book chapter that I have published in this book, Clinical Applications of the Polyvagal Theory. This book was edited by Professor Porges, who's the father of polyvagal theory, and Deb Dana, who is a psychotherapist in the States. The book was published last month in America and it's out in July in the UK. So just to briefly summarise what polyvagal theory is, this is Stephen Porges, Professor Stephen Porges' theory, and this is grossly oversimplifying it, but what Porges says is that one of the main tasks of our body is for the autonomic nervous system to keep us safe. So we've evolved to stay safe, and he calls this neuroception. And he says that we've evolved 3 different pathways within our biology to this end. And he calls these 3 different phylogenetic pathways, which are quite distinct and evolved at 3 different stages in our evolutionary history. So the most recently evolved pathway is the ventral vagal pathway, and psychologically when we're in this mode, we feel safe, we feel calm, and our heart rate is at a nice steady rate. And he calls this the social engagement system. When we perceive threat, we move into a different mode, and that's our fight or flight mode, and we feel anxious and an urge to act, to do something, to keep us safe from that threat, and our heart rate goes up. And physiologically, there's a level of arousal. He then proposes a third, quite distinct system, the dorsal vagal pathway of the parasympathetic nervous system, and when this is activated, we play dead, and this is felt as dissociation, and our heart rate actually plummets. And that's not a safe thing for prolonged periods of time. So this is basically the same model, and but as a kind of window of tolerance. So in the middle zone is what he calls the safe zone, and this is our social engagement system. And it is associated with being able to self-soothe, being able to use social interactions to soothe ourselves, being able to experience a full range of emotions with a general sense of control and awareness of them. Whereas when we're hyper-aroused and we go into that fight or flight response and our thinking tends to be rigid and chaotic, we have poor judgment and we can be quite obsessive because we're hyper-vigilant, looking for that threat. And then underneath the social engagement system is this state of hypoarousal. And we feel numb, hopeless, we shut down, and our bodies physiologically shut down too. So there's an absence of sensations. So the social engagement system is our most evolved and healthy way of being. So this is our monkey brain. And it allows our body to function uninterrupted. So our bodies can focus on growing, developing, learning, recovering and healing, and we feel safe and calm. And we want to mostly operate within this mode. And that path of the vagal nerve that's associated with that actually comes up to our faces. So that part of the vagal nerve actually controls mastication, feeding, vocalising, breathing, head tilt and turn, gaze, facial expression, voice perception and listening. So if you think about it, all of the tasks that are required for communication, and that's what we do as humans, we communicate. And so we need to be in that mode to be able to do that. And if you think back to what I spoke about in terms of the vulnerabilities for people with congenital heart disease, then these were some of the issues that kind of crop up, difficulties along these lines. So how is this relevant to congenital heart disease? So after reading about Porges' theory, I started to think about this. And we know that to successfully adapt to the changing environment, we need to be able to move between those three modes when we're safe, but also when we feel unsafe, to enable our defence mechanisms. And normally our nervous system functions within rhythmic physiological variability, so there's the homeostatic control. And the larger that variability within normal parameters, the healthier we are and the better able we are to respond to the stress of the environment. And Porges talks a lot about respiratory sinus arrhythmia. So this is the natural difference in the breathing cycle. So when we breathe in, our heart rate goes up a bit, and when we breathe out, it goes down. And RSA, or respiratory sinus arrhythmia, has been demonstrated to be a measure of parasympathetic tone that's related to emotional regulation. And so this is a marker or a measure indirectly for neuroception, emotional regulation and general well-being. So if we think about this for people who are born with a heart condition, then it becomes apparent that perhaps any cardiac anomalies might compromise self-regulation, impact the stress response and the tasks of the social engagement system. And if that's so, then there's wide-ranging implications. And what I want to just cover briefly here are implications for attachment, for better humanising medical care, and also to inform therapeutic interventions. So we're all psychologists here, and we know the importance of attachment, that usually baby and the primary caregiver engage in a biological dance. And when that relationship is stable and attuned and safe, then a secure attachment to each other is enabled. And that becomes what Bowlby called the internal working model. So it's the template for self-regulation and for future relationships. And that's been backed now by neurodevelopmental studies by Pat Ogden and Babette Rothschild, for example. So if we think about this, then as a result of their heart condition and in the name of treatment, such babies face significant challenges to fulfilling that biologically driven connectedness with their attachment figure. Both in terms of being incubated, maybe having ventilators, in terms of feeding problems, but also in terms of being able to stay within that safe window of their social engagement system that they need to be in to be able to bond and attach with their mother. And it's also important to bear in mind that until fairly recently, it wasn't uncommon for children to stay in hospital without their primary caregiver who visited just once weekly. It's important to bear that historical context in mind when we consider the lived experience of today's adult survivors, because those individuals may have faced significant medical adversity without the soothing presence of their main caregiver. I've presented this work at a number of different conferences for patients and survivors, and it's not uncommon for people to come up at the end and say to me that they had open heart surgery when they were about 7 years old and stayed in hospital for up to 6 months in oxygen tents recovering in the sort of 60s and 70s without their parents, or the parents maybe visiting on a weekly basis. So in terms of kind of moving forward, we need to promote the soothing presence of the caregiver at the child's side. We also know that touch facilitates the task of the vagus system and expresses compassion, reward and reciprocity and safety. And studies have also shown us that preterm infants gain significantly more weight when they're touched. We also know that compassion is expressed through vocalisation, so it's imperative that we have the caregiver there to be able to touch the baby or the child, sing to them and encourage this practice, not as a secondary thought but actually as part of the care given, as important if not more so than the medical care. We also need to support the mental health of the wider family. Because if we think about things in this model, it's important that mum or dad or whoever the primary caregiver is also able to operate within their social engagement system. And having a baby or a child in hospital seriously ill means they're more likely to be within their fight or flight response or hypo-aroused. So offering them support means that they can be more present for the baby, for that bonding to occur. It's also important to educate parents that their role is absolutely essential, and to validate that it might be harder to feed the baby, that baby might not engage as easily, and that these are all at par for the course so that they don't feel rejected or feel undermined from their parenting skills. Therapeutic interventions might be indicated at times, so these could include touch, play and musical therapies, but of course it's important to bear in mind the individual needs of that child, particularly if you've got a history of body trauma there. So now I wanted to move on to how we can use this knowledge to better humanise medical care. So we know that healthy regulation of the autonomic nervous system is shaped by repeated social interactions, and that predicts whether we find social connection with others safe or frightening. So it's imperative that we minimise any medical disruptions to the biologically driven need for safe social connection. So studies have shown, for example, survival rates increase when doctors make eye contact and provide reassuring touch. So things like good communication and compassion have to be fundamental ingredients of medical training. So this is just a quote here from the mother of a child with a heart condition who contacted me via Twitter actually. And she said that the nurse who told her son that the needle she was going to insert into his arm was looking for worms under his skin probably has no idea how many years of fear and how much ongoing work with him this one sentence actually created. So I think this just demonstrates, how important it is for us to embed this psychological understanding and basic training across the board in anybody that's working with these vulnerable individuals. Building a trusting relationship with care providers also depends on the team remaining consistent and responsive to the individual's needs. Unfortunately, care provision hasn't always evolved in time for the needs of the adult population. And often this growing population, as I said previously, have maybe been discharged as children and then have required care as adults and have been missed by services or unable to access the care we need. And many adult survivors have endured experimental treatment. They grew up during the pioneering days and the expectations of their survival were uncertain. We may also have an increased risk of dissociation, so this population, if there are cardiac anomalies, and that does mean they're more likely to become hypoaroused, there may be more likely to go into a kind of dissociative state, and again that's more likely to happen also if they're exposed to medical trauma. We might also need an alternative means to measure physiological arousal. So if people aren't becoming kind of in that kind of hyper-aroused state, or maybe babies aren't becoming in a hyper-aroused state, but rather in a hypo-aroused state, it might be harder to pick up on pain responses. So measuring things like respiratory sinus arrhythmia and to keep an eye on this are perhaps indicated. Now we might consider everything has changed a lot since the days of James and Joyce Robertson, and in many ways it has. However, there still is a lot of work that needs to be done. So just as an example, this is a study that was done by Bray et al. Just in 2015, and they looked at the practice of forcibly holding children during medical procedures. And they found that 81% of health professionals reported that children are being held forcefully for procedures, either frequently or very frequently, often to get the procedure done quickly. Sometimes a child who says no, stop or wait is not listened to. Children who kick out, cry or try to wriggle away that's not always taken as a sign by the parent or the professional to stop what they're doing. And parents often report that they find that they're surprised and upset and stressed when they're asked to forcibly hold their own child. As psychologists, we know that being forcefully held could cause a child to be scared of coming to hospital, and bearing in mind these are children who will have to come back, and that this might put them off those future procedures, and they might also experience psychological trauma and harm. And although the professional guidelines state that holding a child for a procedure should be a last resort, it continues to be part of everyday practice. So we have some work to do in terms of better humanising medical care. There's many things we could cover today, but just a few things that I would think about would be things like the use of bravery stickers. Does this support, obviously it's good to be rewarded, but at the same time, does this suppress emotions? Does it tell the child that they have to be brave, that they're not allowed to cry, to be upset? And does it reinforce this good patient role? Finally, I just wanted to talk about informing therapeutic practice. So to date, a range of psychological therapies have been used with this population. However, they usually consider the psychological aspects as secondary and indirect outcomes. And therefore treatment is based on the social engagement system, so people being able to be in the social engagement system, such as talking therapies, or maybe being a bit hyper-aroused, so things like focusing on relaxation and behavioural therapies. However, this is a population that are maybe more likely to be hypo-aroused, and it might be that psychological intervention first and foremost needs to focus on safety and stabilisation, so being informed by body psychotherapies and emotional regulation. And this book here came out by Deb Dana, who co-edited the book that I spoke about earlier that my book chapter is in, and this comes out at the same time, and in it she talks about the polyvagal theory in therapy and in therapeutic practice. It's also important, I think, to harness resilience factors. So there is a range of literature that shows post-traumatic growth in people who have endured early adversity. So things like a greater appreciation of life, more resilience, more empathy. So it's important to also build on these skills that members of this population may have. So finally, I just want to talk about how we can affect real change. It's all very good preaching to the converted, but how do we change things within wider society? And I just wanted to talk about some of the opportunities that I've tried to create to use psychological knowledge to improve care, build wider understanding and support, and social connection. So in England, there are congenital heart disease standards, NHS England standards, and in those standards there is a standard that pertains to having a specialist adult congenital heart practitioner psychologist in each of the specialist centres. In Scotland, I discovered that we didn't have standards, and after a number of critical events with my own care as an adult and kind of asking around and finding out I was far from alone, we put a petition into the Scottish Parliament asking for national healthcare standards and also improvements in our care. This was submitted in November of 2012, and I was then invited to become Scottish Campaign Manager voluntarily for the Somerville Foundation. So the Somerville Foundation is a UK-wide charity who work to improve care for adults born with a heart condition. Since then, I've been involved in a lot of lobbying and campaigning. I joined the relevant cross-party group at the Scottish Parliament. I've lobbied MSPs to submit parliamentary questions. I've employed social media a lot, which has mostly been good, occasionally not so good. I've sat on the newly established network, and when this was decommissioned, I've sat on the advisory board that replaced that. These efforts have been reported in BBC Reporting Scotland, STV News, and also in Holyrood, which is the Scottish Parliament's publication. And finally, 6 years later, in January of this year, NSD issued specialist adult and paediatric standards for congenital heart disease in Scotland. This was a huge step forward for us and the first time that we've had standards for our care. And we're now working on developing local standards as well, and they sit with, at the moment, Health Improvement Scotland. You can see here there's just a little picture which came from the BBC News, and this was also reported more recently in the Psychologist. So within these standards, as you can see here, psychology is mentioned and psychological support is mentioned. Like I said, at the moment we still don't have a psychologist at the specialist centre, but hopefully that will change soon. This slide shows some of the other ways in which I have tried to kind of sneak into the medical profession. I've done this by having publications in sort of a patient story in the BMJ, and following up from that I was interviewed by the BMJ student population. There's also a book here that was written by Kate Bull, who's a cardiologist, and she interviewed me for that book. Last year I presented this work as a poster at the Paediatric Cardiology and Cardiac Surgery World Congress in Barcelona. And the book chapter that I've written, I rewrote for layman, in a kind of layman's version, and that was published in The Conversation, which is an online platform where you get kind of, it goes out there and everybody can kind of see it. I also regularly try and present this work as well to people who are living with a heart condition from birth, so that they can be empowered with this knowledge and take that forward themselves. I was also involved in a photography exhibition, so this was a kind of psychologically informed photography exhibition that I developed with two friends who also happened to have been born with a heart condition. Jenny Kumar, who is a PR consultant, and Caroline Wilson, who works for the Herald Group in Scotland. And our idea was for adults to bear their scars from life-saving cardiac surgery to try and challenge negative perceptions about scars. This was launched at the Central Hall of Glasgow's Kelvingrove Art Gallery in February of 2014, and it sat in the Central Hall for a month. It gained national media attention. It was on the STV and BBC News, and we had a 6-page spread in the Saturday Herald magazine. It's since been exhibited at the Scottish Parliament, the Royal College of Surgeons, the Golden Jubilee, the Forth Valley Royal Hospital, and at Glasgow University at the British Heart Foundation's annual conference. So these are just some of the exhibits here. So there's a picture here of Heather, one of our models, who managed to get it into the Women's Institute magazine here. And these are some of the quotes. So, for example, which is exactly what we set out to do, we have a 2-year-old boy who came along to kind of identify with and enjoyed spotting zip lines like his own. And again, Kelvingrove Art Gallery is in walking distance to York Hill Hospital, and some parents had come across whilst their 3-week-old son was having open heart surgery. And on the back of the posters, there was the images on the front and the back, and 100 words. The models had written their own experience and what their life had been like. So finally, I just want to mention kind of future directions. There's a lot of things that need to be done and that I would like to do. At the moment, I'm involved in a collaboration between with Inga Wellbeing, who design patient clothing, and the Congenital Heart Research Centre at the University of Suffolk. I'm an honorary research fellow there, and with them and Inga Wellbeing, we're planning a study to look at the impact of patient clothing. So the kind of thinking is that getting dressed is a process of self-actualisation in which we strive to achieve a fusion between ourselves and what we're wearing. However, hospital clothing, so if you kind of think about hospital gowns, can actually be the opposite. So there's a failed fusion between dress and self. So the instruction to wear a backless gown for medical procedures might add to the sense of disempowerment when you're already feeling rather vulnerable. And that might contribute to PTSD, anxiety and depression. So we're leading a collaborative study to explore that and the lived experience of patients and their relationship with patient clothing while introducing these new clothing that have been developed by Inga Wellbeing. In future studies, we would also like to look at the contrast between what patients wear and then also what medical staff wear, which tends to empower them and how that impacts on that kind of power balance. So just to sum up, I think polyvagal theory provides an embodied understanding of living with a heart condition from birth that hasn't been available to date. And as such, it allows us to develop strategies to optimise feelings of safety, social connection and emotional regulation. It provides a language so that we can communicate this experience to others and supports the development of resilience and autonomy. And it also raises questions, highlights important work that still needs to be done and which can drive future research. So this is just a little quote here from Professor Porges, and he says that when we're with significant others, the responsibility of that relationship is to keep our autonomic nervous systems out of a state of defence. So just bearing that in mind for people who are hospitalised particularly, who have been before and will be again. So this is a list of further reading and again this book. So thank you for listening. Again, I'm sorry that I'm unable to attend in person. If you have any questions, feel free to email me or contact me on social media, and my website is here as well. So there's a lot more information there and links to a lot of my articles, most of which are open access. Thank you.